So I want to welcome everybody to our LinkedIn Live for the launch of iCount. So I'm really pleased that everybody could attend. So thank you for that. And this is, as I said, the official launch of iCount, which is the surgical swab safety system. And we're here to talk about a problem that shouldn't exist. Retained swabs. They're classified as never events, and I know that that's a contentious title at the moment and it's under advisement, but that's still the name for the time being. And unfortunately, they still happen. And when they do, the impact obviously goes way beyond the operating room or the maternity or the labour ward. It's financial, it's cultural, and more importantly, above all, it's human. And today we've brought together what I consider to be an incredible panel to unpack the problem and introduce a solution designed to change the way clinical teams can count swabs. Now, this webinar, as I said, marks the official launch of iCount, hopefully not just as a product, but hopefully as a movement to make surgical swab counting safer, faster and more reliable. And we're beginning the next phase of our iCount journey by partnering with clinical teams who want to pilot iCount and be part of shaping the future of iCount. So firstly, I just want to introduce the panel, which is Aditi Desai, Dr. Aditi Desai, who's a consultant gynecologist, obstetrician, and the inventor of iCount, who turned the clinical challenge we're talking about into an innovation. So welcome, Aditi. Thank you for coming on and sparing your time. And then Catherine O'Reilly, Patient Safety Incident Investigator at University Hospitals Bristol and Western NHS Foundation Trust, bringing frontline perspective on adoption of safety protocols and culture. Welcome, Kath. And then finally, Laura, who is having some problems staying on the line, so I'm just going to try and get her back when we kick off. And Laura is a patient advocate and retained swab survivor, speaking about the hidden toll of retained swabs from a patient's point of view and a human perspective, of course. And as I said, I'll bring Laura into the call shortly. So that would then mean that we've got clinical practice, we've got invention, we've got patient safety, and the human experience. We're all obviously humans, but the human experience is from Laura's point of view, and hopefully that's going to be covered all in one conversation. So I want to kick off really with the problem in terms of retained swabs. So despite all of the systems we have, these never events and retained swabs still happen. So first question to you, Aditi, can you set the scene? Why are we still seeing these incidents, and what's the scale of the hidden costs?
Yeah, so imagine this, you go into hospital to have an operation or to have a childbirth and everything goes fine. You come home and in a few days you start having problems. Start having high fever, pain, discharge, all sorts of things. You approach healthcare individuals, but, things aren't picked up for a little while. And then when your symptoms get worse, you're ill, you go back to the hospital and you're told that something's been left behind. And that's just terrible. You don't expect it. And people have come back with really bad sepsis. It's taken lives as well. So something that's recurrent, it shouldn't happen. And it's indefensible. So we don't really tell patients that, okay, if you have a procedure, we tell patients, okay, you can have infection or rarely damage to internal structures. You cannot tell people that we could, once in a while we'll leave something behind. That's not consented. So it's completely indefensible, and it's the responsibility of the healthcare professions. And it happens again and again. Happens because the system needs strengthening. People ask me, can't health professionals count things before and count things after? Surely it's simple. It's not that simple when you have to do 5 things at once, get them all right in the middle of the night when there are interruptions and distractions. That's the real problem. The swabs look very different when they're soaked with blood. Blood makes them stick together, so you could easily count 1 as 2. And the cost is quite high because when patients come back in, there's the cost of readmission, re-procedures, the litigation, the investigation. For every meeting that happens, right from talking to doctors, taking their statements, all that can amount to around £100,000 easily per incident.
Thank you for that. And just moving on to you, Catherine, because I think that's really set the scene quite nicely in terms of from the hospital point of view, the clinician's point of view, the challenges. From your hospital experience, how do these incidents affect not just patients, but also the clinical teams?
I think they have significant impacts. Aditi mentioned there the physical kind of consequences, the pain, the swelling, necessary repeat surgery. But there's also quite significant psychological impacts because it can really badly affect the relationship between the patients and their healthcare team, because that relationship is based on trust and communication. And if patients feel that they can't now trust their clinical team, they might delay going back to that team, they might delay telling them about symptoms. So it can have real significant patient effects, physical and psychological. I think for staff involved in a retained swab event, or any never event actually, staff often feel quite significant shame and guilt. In my experience, people don't go into work planning to leave swabs in someone that shouldn't be there. And when it happens, they feel really personally responsible. And then, surgical teams are usually quite close-knit. So if there is a retained swab event, everybody knows who it was in a way. It's a never event, so the senior trust managers all know. So the people involved, they feel very anxious about their professional standing, their reputational standing, the impact it might have on them getting jobs, and it leads to staff going off sick and some even leaving their profession. So we lose all of that skill and knowledge and experience that they've got. So yeah, it's huge, significant impacts for patients and staff altogether and teams.
Okay, thanks very much. And I think that it's perfect as Laura's now joined us. So she wasn't on when I was doing the intro. So welcome, Laura. And I think this fits perfectly in terms of just moving on slightly to the actual patient experience, because obviously we've been talking about the patient experience from the clinician's point of view and from the hospital point of view, and that breaking trust between the patient and the healthcare environment. So I just wanted to bring you in there, Laura, because obviously you suffered a retained swab event. Could you share your perspective on what the human impact looks like from your point of view, and then your family as well specifically, because it doesn't just affect you as an individual, does it? It's a wider issue.
Yeah, sure, Hakeem. So it was back in 2020. Not a good year for anyone really with COVID. Just a couple of weeks after I'd given birth to Sienna. What do I say? It's very disturbing still, 4 years on, to think that, it's still reoccurring. It's still very much a problem. And it shouldn't be. Yeah, so it was roughly 2 weeks after I had given birth, and I was in the living room with my daughter. I did generally feel very poorly, but with it being my first baby, I wasn't sure if this was something that should be felt, the pain. And if we fast forward, say a couple of weeks, I had swelling legs that were getting kind of worse from the ankle upwards. I felt dizzy, lightheaded, very faint. I found it very hard to breastfeed. Yeah, it's a very traumatic time. Obviously, I didn't know at the time that I had a retained tampon. I went from the living room into the kitchen to do Sienna feed, and so I expressed some milk, come back into the living room, and then I felt the urge to go to the toilet. So I went up and used the toilet, and it felt like I was giving birth again, with what I can only describe as kind of like a 2 to 2.5 inch blood clot that I lost, which again, I wasn't sure, was this something that was meant to happen? So as advised by the community health team in the Red Book to give triage a call, if I required any help or advice, and which I did do. So I called the hospital, and I was advised to go along to triage. Again, a very difficult time. I'd been at home for 10 days, forming that bond with Sienna, and I had to leave her, so I was expressing the milk from my partner, her dad, to feed her. again, not wanting to leave her so suddenly, but I had to because, like I say, I was very, very weak with this swelling coming protrusively up my leg, very feverish, faint. So it was in our best interest to get myself checked out. So I went along. I drove up to the hospital, which was roughly 15 to 20 minutes away. I arrived at the hospital where I was asked to wait in the waiting room until a healthcare assistant could see me. So I think I waited about half an hour, and then I was asked to be taken into a room, which I was. I went into a room and I was asked to lay down on the bed, and I give all my symptoms. Now, whilst passing the blood clot.
I think if you can stop there, but just give us a quick overview on what the impact has been since then, because I think a lot of people will be feeling your emotion there and understanding what you went through, but then just understanding 5 years later what's been the 5 years later what's been the impact. So that's a cliffhanger. Laura will drop out. As I said, Laura's been having some problems with her connectivity, so I'm sure she'll be back in just to finish that off. Just in the meantime, it's probably worthwhile just taking a second to reflect on the poll that we did, which was effectively, why do you think retained swabs actually still happen in maternity and surgery? And just before I go into that, I'll just come back to Aditi and Catherine just to give a comment on what you thought about what Laura was just saying there.
Yes, it's a typical patient story. And you can see even now, although it's been 4 or 5 years since it's happened, she still brings the tears on. And I mean, I've seen patients where this has been discovered when they are really ill and they've had to have the full course of antibiotics, be admitted in intensive care, and all their stitches have broken down because of the infection. So she's shown a lot of courage to actually share that story with us. And I just think that's quite brave, actually.
Yeah. Any thoughts, Catherine?
I think, absolutely. Just so brave to be able to say that. And also it's just horrendous to have that happen and to have that still impacting you 5 years afterwards. It's just, it shouldn't be happening. The impact on patients is terrible. There has to be a better way.
Yeah, which and hopefully there is. And I think this is really interesting. We were talking about off air at the beginning, where if you look at the poll results, then it's basically saying that 50% of the people who responded said that they think it's a system and a process failure, which I think is really interesting. So just to you, Aditi, first. What are your thoughts on this? Because I know that you're all about human factors and systems, so this is probably exactly what you're expecting.
Traditionally, this was first reported, swabs retained, in 1881. So it's as long ago as that, ever since surgery has been taking place and childbirth. So all this while, it was always that, okay, one should do the counts. That's the count policy. The staff have to follow the count policy, count them correctly before and after. And if they get it wrong, then it's their fault. So they haven't followed policy. Then a lot of reprimanding and reminding and that kind of thing happens quite a lot. I'm sure even now. But fortunately, things are changing. So other industries like defense or rail industry or aviation, they've moved away from this approach. Of course, individuals are accountable, but the system is important as well. So are we making the task better? Are we making the tools better? Is the environment better? Is the organization looking at the whole picture? So there is a lot of work in that area, and there are things like patient safety incident response framework that the NHS England has introduced, which is actually quite great. Yeah. And it looks at all these things. So the gist is that, are we making it easier for staff to do the right thing.
Yeah,
So,
exactly. And I think that, as I said, it's not a surprise to you. I think what you've seen here, and that's one of the reasons why you saw a gap and decided to innovate. So Catherine, over to you.
Yeah.
What are your thoughts on these results?
I think 50% is really quite good. I think Aditi mentioned the patient safety incident response framework, which has only been, well, it's still being implemented in different trusts now. So it's not fully embedded, but it is getting that systems approach. It's looking at those parts, those interconnected parts of the system and how they all impact on each other. And I think that 50% shows that that is starting to come through. I think if we'd done that survey a few years ago, it wouldn't have been that high, honestly. And I also think, in some ways with swabs, people haven't been given the easiest way to do them. The old national guidance for over 10 years has all relied on the manual swab count, and the manual swab count just isn't reliable. So I think people have been working in a system that really hasn't supported them as well as it could have. But I think 50% is good, and I think it will go up. I hope it will go up.
Yeah, no, hopefully, and I think it's really interesting because it's against that backdrop of human factors and system approach and that manual count that Aditi and her husband, so I can't leave Kieran out, developed and decided to develop the iCount to deal with this exact problem, that problem of manual counting and the system and the process failures. So I think it's just worthwhile. Aditi, can you just take us back a bit to what inspired you to create the iCount in the first place? Probably some of what you've just discussed. And then what gap did you see in the clinical practice workflow? And then how did that allow you to turn that into a working product? Because I think that's really important for people to understand how it was developed and what the gap was.
it is quite a long journey. It started in 2018 after a series of patient incidents in the region and nationally, and alerts coming through just to be more mindful, careful, follow policy. So we thought, something had to change. Whatever we're doing is clearly not working. So we formed a little group of midwives, doctors, and actually some patient representatives. We went to Keele University, who helped us with a tiny little grant to get started. And we tried to think, how do we make the process better? How do we make the system more resilient? And the more we thought about it, we came to this conclusion that we needed something which could make it easier for staff to actually spot all the swabs correctly. So we needed something where we could see each swab docked individually, counted in fives before and after. If there was an additional tampon used, then have another slot for a tampon. And when we did early simulations with early prototypes, it kind of seemed to work. And that's how we went on and on. We went through 18 iterations. So we worked with Wolverhampton University, the Manufacturing Technology Centre, which is one of the government's high-value catapults. We worked with manufacturers like Kimmel. And then we had a device, which is a simple device, which actually shows the count correctly. So one has to just clip in all these swabs, which come in with their tails, and they get docked in, and you can see them individually, count them correctly. We also did simulation in the University Hospitals Birmingham high fidelity suite, and we were able to demonstrate, and this was done independently, that there was around 37% time saving because there's no need to document it on the whiteboard. So I can't go into all the details, but here we are with the device, which simulation has shown clearly that it increases the user confidence in the accuracy of the counts, and they find it easier.
Excellent. So thanks for that. And obviously you can't go into it all because we've only got a short period of time, but obviously everybody on the call has our details and can just DM us if you want more information. But moving on, Catherine, so let's try and make this a bit more real for people watching. So in your capacity, how do you envisage this working in your trust in practice, and what difference do you think it'd make?
So I think healthcare has a tendency to add more and more procedures and tasks to try and make an activity safer, but we end up with what you call safety clutter. So you've got more things that aren't really effective, but make the system more complex and ineffective. So what I would hope is that it would replace, as Aditi says, replace some of those actions that we currently take as part of swab management that aren't as effective or reliable, so that we remove something that doesn't have good value as a safety feature and replace it with something that does. And actually, we'll need that if we're going to get buy-in from staff with any new process or equipment. So really, I would hope that it frees up clinical staff to focus on strong safety actions. And I would hope that it would make swab counting more reliable, more accurate, easier, and less taxing, because it's a very complex, fast-paced, changeable environment. So I would hope that it would free up staff cognitive resources and reduce the number of physical activities that we currently have in swab management, and ultimately, have better outcomes for patients and staff, so that we don't have retained swabs, we don't have staff as second victims. That's my hope. Details of practice we are currently working through as how it fits into current work streams, because among other things, and we don't currently use in our labour rooms, our swabs don't have tails, so that using the system would involve a change in our current ordering. So there's nuances to it that people would need to think about. But yeah, hopefully it would make it safer, definitely.
And just on that point, because we were talking about it a bit before off camera, so what do you feel that hospitals need to do before adopting something new like this so it's actually successful? Because we've all seen products that come that sound great, but then they don't get adopted because actually they've not been introduced correctly. I
think the first thing a trust needs to do is recognise that these events happen because of system factors and system failures. So we need to address those systems and processes and not just tell people to be more careful when they're counting. So I think organisations have to be more open to change, and they need that mindset and the structures and the resources to support change. So for some organisations, they'll need to see a shift in thinking to a systems approach before they would even consider something like this. I think there's a mindset issue that might need to be addressed. I think any organisation will want to see that there's been rigorous testing before it comes into the hospital, which is absolutely as you'd expect. I think an organisation needs to identify what risks will be reduced or removed, and any new equipment, it has to be practicable and usable by staff. So again, that comes back to bringing the people who are actually going to be using it with you early on. And I think the organisation needs to see the potential benefits, and I think they need to look at different ways of measuring wider impacts of retained swab events, because most organisations don't have multiple retained swab events every year. So if they are looking just at overall numbers, they wouldn't possibly see the benefits. So I think they'll need to have, like you mentioned, Aditi, an idea of the time saved by changing their processes. They'll need to be able to measure and understand staff satisfaction and well-being. And ideally, they should have a baseline for that before introducing something, so that they can see the direct impacts. So I think there can be a lot of foundation building before something new would come in to really get benefit of it.
So that's a brilliant perspective. I think we've lost Hakeem there. Yeah. But I just think it's not just about this problem, change swabs or never events. I feel that they are the tip of the iceberg, and there are many, many patient safety incidents. Some of them affect patients a lot more than retained swabs even. If we can change the outlook and the way we look at patient safety using some framework like SEEPS, which is system engineering in patient safety, where one gets a bird's eye view of what is actually happening, so that the changes are collaborative and coherent, and actually look at the entire picture rather than this fragmented approach that's been going on, it would work a lot better. It's been demonstrated in several other industries, and I think it's high time that we get that into healthcare. And it's not just about never events and retained swabs. If we can translate it to other problems, then that would go quite far. I don't know whether there are any questions?
So I think it is a good sign, though, that that healthcare is moving forward in that systems approach. Because, like you say, aviation and nuclear, they've all, they've got a long history, and we're kind of playing catch up in a way, and having to take some of what they've done and make it work for us, because it's a completely, it's a different environment. But I think that whole concept of a systems approach and human factors and seeing the interconnectedness, I think that can only improve outcomes for patients, I think, in the long term.
Yeah, there's some midwives, some theatre nurse leads. We've got a comment from Sandeep Ark, who's the theatre lead at Harborne, I believe. So she says she feels that she was asking whether swab retention incidents have increased in line with theatre activity increase. So I would say the incidents are around 70 per year. They go up and down, but there's some research to show that not all incidents are reported, although they should. So we don't really know the exact numbers extremely accurately, but there hasn't been any evident increase in the numbers to see from the data. Nigel feels that, the innovative Nigel, who's the associate divisional director of theatres, not able to bring up where, but he feels that the product will help with accurate counting and reduce intraoperative never events and patient harm. He's done a PhD on never events. There's another comment from a senior operating department practitioner who is, and they're really, really important in theatres to keep the whole show running. So he feels that it's an innovative product, but this is a genuine question. He says, do we need all the plastic and the extra steps involved in using it? At the end, it is the mutual respect and within the multidisciplinary team. So, point well taken. We had a lot of thought and a lot of work put into how to make sure this is green. So we've used the least amount of plastic. Now, plastic overall is not great, but it does its job. So if you wake up in the morning and just look at the number of things that are used of plastic, well, that many things that are used, that's because it does its job. As long as we reduce the actual amount that we have to use, and we do a life cycle analysis to show that the overall it leads to carbon savings, then that's good enough. And we did do a very detailed life cycle analysis of how, what happens when there's a never event. And also we can reduce the kind of swabs, the size of the swabs that are used in these procedures. And that leads to a net carbon saving of half a kilogram per procedure. So we had this done by an independent agency. So that answers that question. And we could move on to bioplastics, but they are expensive. So the healthcare organizations have to bear that cost if we have to move there.
I think, yes, on the underreporting, I think what we miss is the near misses. And, and the stress and the anxiety that they cause, and the knock-on effect to theatre lists as well, of then having to search for swabs. And because you could conceivably spend so much time searching for swabs that the last person on your theatre list gets dropped. These are there are wider consequences, I think. But yeah, I think you're absolutely right. With all incidents, there's underreporting, definitely. So I think there is there's a certain number of them that are definitely hidden. Yeah.
Oh.
So it's probably a bigger problem than we realise.
I'll let Hakeem lead again. We're just answering some of the questions that have come up.
Excellent. I do apologise. For some reason, my wife decided this was the best time to turn the internet off. Anyway, you're answering some of the questions, so that's fine. So I don't know, Laura, I don't know if we brought you back in just in terms of your views on obviously the iCount, because I know that obviously Aditi has been talking about from your point of view. How do you think that may have changed what happened to you?
Yeah, I think the device in itself, Hakeem, is a brilliant idea. I think it's very clear. Like you say, midwives in particular, they do, 12 hours plus on a shift, doing 4 or 5 different things at once. suturing. But the fact there's always 2 people there, 2 midwives, or a midwife, and I suppose a house care assistant, and for it to be a reoccurring issue, then something needs to be done. You know, it's like, it's a seatbelt for safety, isn't it? You get in the car, the first thing you do is put your seatbelt on. You need safety. You want to prevent anything from happening. But if it's a reoccurring problem, then it's an issue, isn't it? And I think, you know, something definitely needs to be done. I think it's a great idea.
Thank you very much, and I'm sure Aditi appreciates that. So are you putting your hand up because you want to say something, Aditi, or are you saying thanks to Laura?
I'll just first respond to Laura that it's great to hear from patients, and we've involved patients in the entire journey, and the way it looks like now, the color, that's actually been suggested by patients. So it's great to hear that you like the ethos of the device. I was just going to talk about a question that Fran Ives has asked. Fran Ives is the president-elect of the Chartered Institute of Ergonomics and Human Factors. So that's the top organization which leads this specialty, which I think is a brilliant thing for all industries. So she's asked, did your knowledge of human factors influence the development of iCount? The answer is very much so. So when we started doing this, I actually felt quite uncomfortable with my understanding of this. And I presented this at the Royal Society of Medicine in London. I met a human factors professor there, and she said, your approach is good. You want to do the right thing, but you need a lot more nuance. So when we started corresponding about, various things that I could do, I realized that my knowledge wasn't adequate. So I went back to Loughborough University to actually do a qualification in human factors and patient safety. And that's when a whole world opened up of how one should look at these, investigate these, and think about various solutions. So yeah, very much so. Thank you for that.
Okay, so thanks for that, and that's really important actually, and I think that goes back to what we were saying in that questionnaire about it being a systems and process issue.
Comment from Atman saying that thank you, Laura, for sharing your story so bravely, and your strength touches everyone listening and reminds us of why safer care truly matters.
Yeah, indeed.
Oh, thank you.
And I think Emma Finley also said the same thing and echoed that sentiment. Now, I'm just mindful of the time, and I'm mindful that I like to be respectful of people's time. Yeah. So if there's any further questions, then we'll make sure that they get answered, and we'll send out the answers to those questions if we don't manage to get through all the questions, because our time is up. So I want to take this opportunity to thank our panel, Aditi, Catherine and Laura, and obviously everyone who joined us live. Because as I said at the outset, this launch isn't about selling, as hopefully you saw. It's about starting partnerships. So obviously, if your organisation is as passionate about preventing never events, so that most people are, most clinicians are, then we'd love to collaborate on pilot projects together and gather some real-world insights. So feel free to follow the iCount page here on LinkedIn, and I will send out the replay to everyone who's attended and all the people that couldn't make it today that signed up. And please share with your colleagues and message us if you're interested, as I said, in taking part of the pilots, because hopefully together we'll be able to make counting confidence the new standard in both maternity and surgical safety. So thank you, everybody.
Thank you.
Yeah, thank you.
Thank you, everyone.
From the entire iCount team.
Thank you very much.
Thank you for presenting them. So, bye-bye.
Bye.
Thank you.